do a bit of work, don't hesitate. And we can see your slide as well, Mikk. Perfect, in full screen mode as well.
Okay. Should I will stop sharing. Yeah.
Yeah. Yes.
Yeah.
So can I try one more time so I can see if I can advance the slides. Yeah. One more time.
Mm-hmm.
So can you see my slides?
Yes, we can see.
Yep.
Yes. And it's advancing as well. Yes.
Yeah. Then I will stop.
Perfect.
Okay. Great. So we have some time. Yes, I will close the microphone for a while.
Weitergeht.
Geht. Komm, ich versuche.
Sicher? Brauchen Sie mich dann?
Bleiben Sie, bis ich dran bin, in der Nähe.
Außen.
Lucy? We can see the screen and not the slide in case.
Ladies and gentlemen, I welcome you to the... Sorry, there's some noise. Maybe everybody can close the microphones who's not on the stage. So I welcome you to the first webinar on corneal inflammation and infections organized by the ERN-EYE working group for anterior segment. And we're lucky to attract well-regarded experts on this field. And we put together an interesting program that is mostly infectious, but also we have some non-infectious causes of keratitis on the line. And we start with herpes viruses. And it's a pleasure for me to introduce my boss, Thomas Reinhard, who is a well-respected expert in exactly that field. And we are really excited to hear your presentation, Thomas, and you have the stage. So maybe you can open your microphone. Yeah, exactly.
Now it should work.
Yeah, perfect.
Now it works. Everybody can hear me.
Yes, we can hear you, but we don't see the slides.
Okay. First of all, I would like to thank the organizers, Professor Žemaitienė from Kauno and Daniel Böhringer from Freiburg. Ladies and gentlemen, colleagues, herpes simplex virus eye disease normally starts with a primary infection that is mostly blepharitis, as you can see here in the first picture. But we may also have...
Sorry, we don't see the slides yet.
You don't see the slides? What should I change?
Teilen, share.
I think I had. Now it works?
Still nothing to see here.
Let's try again. You can see it now?
Still not, so I would suggest to let the organizers jump in and, or maybe you fix it.
Well, I propose to share the presentation of Professor Reinhard
But
directly.
I think that they got it. Okay, it's working. We see it. Perfect.
Okay, great, perfect.
You can see it?
Yes, it's working.
Perfect.
Okay. You can see the first slide and now the second slide.
Yeah, perfect.
You do? Great. Herpes simplex virus disease normally starts with primary infection of the lids, blepharitis, or of the eye, less often intermarginal blepharitis, conjunctivitis, limbitis, keratitis, iritis, and swelling of the lymph nodes. Acute conjunctivitis of herpes simplex virus disease looks quite similar to adenoviral conjunctivitis. From a clinical point of view, one often cannot make the differential diagnosis. However, the age of primary herpes simplex virus disease is between 1 and 5 years of age, so very early. Almost everybody of us sometimes had a primary infection, and then the virus gets into the ganglion gasseri, into the neurons, and it persists, and it waits for a chance to come down and to infect again and form a recurrence the eye. And that time, the virus does not prefer the lid of the conjunctival cells, but it prefers the cornea, the iris, the trabecular meshwork, and just producing some alteration of the eye that is indeed visual harming. Rainer Sundmacher, some decades ago, brought together all the different possibilities of recurrence in the eye. Of course, we may have blepharitis, but that is not very usual. We may have intermarginal blepharitis, again, not very usual, and limbitis either is not. But more we have dendritic keratitis, ulceration and infiltration, and endotheliitis, which we called in former times disciformis in Germany. We may have trabeculitis, iritis, and alteration of the sclera in form of scleritis. Let's start with the dendritic ulcer. Here we have cytolysis of the epithelial cells. From my point of view, it's pathognomonic. One scene one never forgets. It looks indeed as a kind of tree, and we normally don't need laboratory diagnostics in order to do the diagnosis. Therapy is abrasion, former times, and for the last 30-40 years we had acyclovir 3% ointment. That is different to the USA. They don't have the ointment. It is not approved by the FDA. They only have tablets. So they must administer tablets. In Europe, we have acyclovir ointment, and we may perform therapy with the ointment, topical therapy. Acyclovir is similar to guanosine. It inhibits the viral DNA polymerase. And first of all, it has to be activated mostly by phosphorylation. It is selective for cells that are invaded by the virus. So it normally does not perform or alter, let me say, alter the epithelial cells. That is quite different to trifluotimidine, similar to timidine, that has a bad penetration. It can only be used if the epithelium is harmed, and it is not only acting in the virus-infected cells, but in all epithelial cells. So you have epithelial disorders. Immune stimulation with interferon alpha is an old therapeutic regime we had some 30 years ago. In the meantime, interferon alpha has been withdrawn from the market, so it is not available. In combination with trifluotimidine for dendritic ulcers, it was most effective, more effective than acyclovir. As a fourth possibility to treat dendritic ulcer, we have ganciclovir. Ganciclovir, again, is similar to guanosine. It is to be activated by phosphorylation, and we administer it. It penetrates well, but we administer it only if there is no response to acyclovir. For example, if there is a resistance of the virus against the drug. In stromal infiltrates, as seen here, ulcers, what we see in the center of the infiltration is the Dismuth membrane, and endotheliitis, seen in the right, we have cytolysis, so the keratocytes in the picture left and the endothelium in the picture right are destroyed, and we have an immunological reaction. And what you see white in the left picture are lymphocytes and macrophages and granulocytes invading the cornea. So we don't see the virus, but we see the immunological response. And the precipitates you see on the endothelium, these are lymphocytes. Again, immunological response. And that is the reason why, in contrast to the dendritic disease, dendritic keratitis, we not only have to perform therapy regarding the virus, but also we have to perform therapy regarding the immunological response. And you can see here, we administer in such cases acyclovir ointment 5 times a day, TFT only in case of epithelial disorders. That means if the epithelium is open, if you have an ulcer, you may administer TFT. Otherwise, acyclovir is the better treatment. And at the meantime, we have to administer topically steroids as injection, for example, underneath the conjunctiva, or as an ointment. Acyclovir is only available as ointment, and an old rule in pharmacology is to to administer ointments with ointments or drops with drops. So if we only have acyclovir ointment, we have to combine it with steroids ointments. Systemical treatment is only necessary in most severe cases in herpes keratitis. And here of course, we have the tablets as in the USA as well. And we administer orally some corticosteroid, mostly fluorocortisone, 20 or 30 milligram in all. If we compare the therapies for dendritic keratitis, we see that acyclovir treatment is most effective, more effective than abrasion, than placebo, of course, and all the old virostatic medications we had in former times. So trifluortomidine is almost as effective, but you have to be sure that the epithelium is really altered. In dendritic keratitis, of course, that is the case. It is often difficult to differentiate between keratitis with viral replication and without. If there is no viral replication, we talk of metaherpetic epithelial disorders. And you could see here dendritic formation. But if you look exactly, if you go back to one of my first slides, it really looks completely different from a dendritic ulcer with viral replication, completely different. And here, of course, we don't have to administer virostatic medication, but we have to do something for epithelial protection. That means lubricants. Here in that table, you see the 4 different possibilities of involvement of cornea in herpes simplex virus disease. We have to differentiate between, is it epithelial or deep? And we have to differentiate between, is there virus replication or not? If there is, we talk of viral disease. If not, we talk of metaherpetic disease. If there is viral replication and it's only superficial, we have to administer virostasis. For example, acyclovir ointment. If it is deep and metaherpetic, we have to administer some medication for epithelial regeneration, some lubricant without virostatic medication. If it is deep and if there's viral replication, we have to administer acyclovir in combination with steroids, for example, in case of infiltration, deep ulcers, or endothelial disease. And if it is deep and metaherpetic, we have a scar and we perform mostly keratoplasty. That is the case here. As you can see, we have some old precipitates, but we have a scar and you will only heal and have some advantages forthcoming for the patient if you perform keratoplasty. That is an example for viral herpes simplex virus eritis, and here you have to administer acyclovir and corticosteroids systemically. You mustn't give them only topically. It's not enough. Always when you have iritis and trabeculitis, you have to administer the combination systemically. It's not enough to do it topically. What can we do as prophylaxis? We can administer acyclovir 2 times a day, 400 milligram, or valacyclovir is an alternative, 1 tablet, 500 milligram per day. It penetrates in a better way than acyclovir without the valine combined with a medication. And you can see that prophylaxis, of course, doesn't mean we get to 0, but it lowers the rate of recurrence in the patients. And if we have every 2 or 3 or 4 weeks, 6 weeks, a recurrence, I administer that prophylaxis, and mostly it is effective. Differential diagnosis, especially the other 3 types of viruses in the herpes group, that is CMV, cytomegalomy. I don't have pictures of that in the adult or pediatric patient. Mostly, most patients are born with the disease and of course have some viral opacification of the cornea. I would like to talk here about varicella zoster virus infection. In contrast to herpes simplex virus, after the primary infection, the virus is in the glial cells, in the ganglioglycerine. It's not in the neurons, and it waits for a chance to come down, to come to the cornea. It mostly comes down only once, and there's a great difference to herpes simplex virus disease. Herpes simplex virus may come down several times. Varicella zoster virus mostly only comes down once. And what we have then, maybe in the eye, keratitis, endotheliitis as seen on the left, or iritis as seen in the right. We administer in such cases on an intravenous basis acyclovir, mostly 2 grams per day. In these cases, in combination with steroid. If the eye is not altered or harmed, I would prefer only the virostatic therapy in order to come down and to bring back the virus into its shelter. We have to expect varicella zoster virus infection of the eye in many cases where the nose, the Hutchinson sign, where the nose is involved. So if the nose is involved, look at the patient every day in order not to overview the disease of the eye. Varicella zoster virus may involve the cornea in a chronic way. Here, of course, we have infiltration of the keratocytes. So there's viral replication in the keratocytes of the cornea. And what is whitish, that is again the immunological infiltration. Here we have again macrophages and lymphocytes gathering around infiltrated keratocytes where viral replication takes place. We have made the experience that acyclovir administration on a intravenous basis or topically is mostly inefficient. Here we treat mostly the immunological response with steroids or in the long run with cyclosporin A 2% in order to avoid the many complications of steroids. For example, 25% steroid response, glaucoma in the long run, and it is often overlooked. Another example for chronic keratitis in viral zoster virus infection, limbitis with involvement of the peripheral cornea. And if we look in the long run, there may be scarring, and here we have chronic interstitial keratitis that leads to blinding of the patient on the side involved. Mostly it's unilateral. But if we have such a case, the only thing that helps is, of course, keratoplasty in order to restore vision. And that, of course, doesn't concern the cornea, but the vitreous and the retina in viral zoster, in varicella zoster virus infection, we may have an infiltration of the vitreous and of the retina. Here we have retinal necrosis, and again we administer in a systemic way the virus stasis in combination with steroids in order to avoid holes in the retina that makes necessary to perform a vitrectomy and closing of the hole. My last slide concerns Epstein-Barr virus. It's again a virus of the herpes group, and up to 2004, when I published that, there were only 12 cases. That is the 13th case in the world literature published regarding EBV infection. Here we have precipitates and some infiltrates of the cornea. We suspected EBV infection. The patient had kissing disease before, and we were able to make sure that there is viral replication in the anterior chamber of EBV, and thus we concluded that there is viral infection, EBV infection of the cornea. And we treated it quite similarly as shown before with the herpes simplex viral disease, combination of acyclovir and steroids on a topical basis, and that indeed is the same eye a week later or 2 weeks later, and all precipitates and infiltrates in the cornea have gone. That is all I have to say for today. I thank you for your attention.
Thank you very much, Thomas, for this excellent presentation. And I think we will move the discussion to the rear of this webinar, and we will proceed with the next presentation. And it's my turn to give a presentation on the management of acanthamoeba keratitis on behalf of Professor Fuchsluger from Rostock, who is not able to do it himself. And so I jumped in, and I will share now my presentation. So this do you see now the presentation?
Yes.
Thank you. Excellent. So I will start my presentation to get us all on the same level with a short overview of the clinical presentation of acanthamoeba keratitis. Then I will bring some facts on epidemiology, and then we go to the gist of my talk, where it is about diagnostic strategies and the treatment, obviously. And this is a panel of different corneal presentations of acanthamoeba keratitis, taken from a review article. And you can see that in the initial phase of the disease, that is mostly the first two rows on this tableau, there is the epithelial involvement that may look like a little bit like keratitis, punctate keratitis, or even like the herpes dendrites or the metaherpetic dendrites. And in this stage of the disease, that can be up to a month. But in this area, we have a red eye with a dirty epithelium, as it is told. It's quite unspecific and may not be recognized as acanthamoeba keratitis. And as we will come to that later. And as the disease progresses, a month or so after the infection, we get some more characteristic features, and that is the perineural infiltration, where the infiltration has somehow a linear pattern correlating with the nerve fibers of the cornea. And you can see this in the bottom row of this tableau, and this is paralleled with pain in the patient mostly. And we also have some stromal infiltrates. And if the disease progresses further, we get more of a stromal infection, and we get this ring-shaped lesion that is quite typical, and then it's more likely that the disease is recognized on a clinical basis. And this can progress to intraocular infection, as you see on this right hand side picture, where we have a hypopyon that is a reaction on some say it's on some bacteria that are living along with the amoeba. Maybe it's a combination. And then there is always the risk of perforation and losing of the eyeball when the disease is not limited in this stage. We come to that later. And there is also the possibility that other tissues can get involved. It's quite rare, but you see here a photo of a patient that has scleroidal abscess. It's what we saw in our hospital, but we see some other reports in the literature. It's quite rare, but this is really serious. So you have to be aware of it. If you don't get the infection treated early enough, you can sort of risk the eyeball. So it's really a serious disease, rare but serious, and it's really rare, as you can see in the next in this slide, where we have a overview of the prevalence. It's sort of a problem to get the real prevalence because it's not, at least not in Germany, it's not a disease where you have mandatory reporting, and it's even rare with the ERN standards, or the rare disease definition, which is 1 by 2000. It's the definition of a rare disease, and we are really, luckily, we are lower than that number. And the numbers from Germany cannot be really take for real, as we, I think the real number must be higher, as we surely have some degree of underreporting in our registry that is from our society. And there's seasonal dynamics with more reports coming in the summer months in comparison to the colder months. And we have a strong feature that links amoeba keratitis or corneal infections from acanthamoeba to contact lens issues. So we have in the developed countries, we have a strong association with contact lens wear, and this is going along with a year of presentation that's more in the first half of the life. And there's a smaller cluster that is sort of more in the not so developed countries, such as, for example, India, where we have farmers that also have this kind of corneal disease. And the literature is not so, it's not a key focus on the medical literature, as we have a peak of 150 reports per year in PubMed. So let's come back to the clinical side. The diagnostic is also always based on medical history, and the key features in medical history are the contact lens wear question, whether it's unilateral. The most presentations are unilateral, and I already mentioned that we have pain as a key feature, but it's not in the first days of the infection. It's coming later. And you can also get some additional insights if you look on the contact lens hygiene, if you look on how the storage is done by the patient, and if you see something like that on this slide, you will have to go strong in the direction of acanthamoeba keratitis. And following the medical history, we do the clinical examination, and I already mentioned that we have this sort of a chameleon style pattern with this dirty epithelium that can disguise as metaherpetic issues, as dendritic keratitis, or dry eye, or adenoviral residues. But if you follow the patient closely and you see that the antiviral treatment does not help and lubricants do not help. It's always the red eye in this stage that is a key feature. It's more red than you would suspect from dry eye alone. And if you follow the patient for a period of 30 days or 60 days, then you will see that characteristic features arise. And that is the main problem, as we will see that the diagnosis is made a little bit too late, or can be made too late if the ophthalmologist is not experienced and possibly does not know this rare disease. But if you see the ring infiltrate, then it's really the stage of the disease where we have to fear to lose the eyeball if we don't do the right treatment. And if we are not so sure in the early stages of the disease, there has been a interesting tool to get in the get some confidence in the diagnosis. That is confocal microscopy. This is the picture on this slide is the Rostock corneal module for the Heidelberg tomograph, and you can see the cysts from the amoeba as bright white dots in the first two rows of this tableau. And in the lower row, you can see the trophozoites. That these are larger and can also be ring-shaped. You can really see that it's a multicellular organism on this modality. But unfortunately, the device is no longer produced, and you can only buy it second-hand, or maybe in the future cannot buy it at all. At least this is at the time we speak. Maybe some other device will come on the market, as there really is this demand for such a device. As you can see on the next slide, the alternative modalities for diagnosis are polymerase chain reaction and the culture, and these suffer from poor sensitivity. As you can see that the study here from Arun et al. Brought up 150 patients, and the majority of these had positive confocal microscopy, but a minority only had PCR positive results, and or culture results was even lower than chance to get a positive finding. But on the other hand, the specificity is really good for PCR and culture. So if you have a positive finding, you know what's going on. But if you have a negative finding, it doesn't mean anything, and you have still to proceed with a diagnosis of acanthamoeba if the other signs are going into that direction. And then it's the time to start the treatment, and the treatment is based on looking at the dynamics of the infection. And if we have an ongoing infection that is not going to threat the integrity of the eyeball or the limbus, we will start with conservative treatment. I will show you in a second how we do it and what others are doing. And if we have the danger of getting a perforation, or if we do not our conservative treatment does not bring the infection under control, we have to do keratoplasty show or emergency keratoplasty to reduce the load of the infection and to give a tectonic support for the eyeball. And this is not something else than to restore vision if the infection is cleared after a year or so. This is another topic I will not cover today, so it's only about the infection. So, and the start obviously is the topical or the medical treatment, and we have two approaches here. We have this PHMB, we can alternatively use chlorhexidine. This is a disinfectant, and the traditional concentration was 0.2%, and this is often combined with another disinfectant that is propamidine, and is often also combined with antibiotics. So that we have commonly a triple therapy, high intensity topical. And a modern alternative to this is the PHMB 0.08% monotherapy, a higher concentration, but this is really expensive. It's a labeled solution that recently came on the market. It's really expensive, and it's sort of equal to the traditional approach. We will see it in the next slide. And you have to decide for yourself, because it's really hard to get this reimbursed, the high cost of this commercial approach with monotherapy. And there's also the option of having systemic treatment with voriconazole or miltefosine. It's not used commonly, but we find it in the literature. And we also talked that about the surgical approach, and that I will detail it in the next slides. The mainstay is, of course, the penetrating keratoplasty that can be combined with intraoperative cryocoagulation to reduce the infection load in the host rim. And this is a retrospective analysis on the different treatment combinations from the traditional approach with the 0.02% PHMB with or without this diamidine. And you can see that the difference is not so high, with a tendency of the combination being more effective in comparison to the monotherapy. And that said, the monotherapy, it's not on this slide, it's more recently been made available, that is sort of equal to that. And this is how we do it in Eye Center Freiburg. We have the 0.02% compounded in our hospital pharmacy, as this is not a labeled treatment that you can just buy. And then we combine it with a propamidine, which is called Berlin in Germany, 0.1. And the idea is that the two different agents are affecting both the trophozoites and the cysts to get the infection really cleared. And we combine it with antibiotics in a lower dosage. These two drops are initially administered every 15 minutes, exchanging each other. So really high intensity over day and night for one day, and then only once an hour or so tapered. But we keep it for 1 year or half a year or 1 year, depending on the infection. And the antibiotics are given less frequently. And we also add voriconazole topically. That is also compounded by our pharmacy, because that is also effective against the trophozoites. And we also add a simple aminoglycoside eye drop for addressing the trophozoites and maybe some bacteria that associate with the trophozoites and give them nourishing them. So this is our Freiburg approach, high intensity and multimodal. And when this does not work, we saw it in the flow diagram, then we have to do the surgery to protect the integrity of the eyeball and to clear the infective load, because when the infection does not clear from drops alone, we have only this option to reduce the antigenic load. Then we do at keratoplasty I show, but not for visual restoration, but for saving the eyeball, and that can be combined with the cryotherapy, as I already mentioned. You can see it on the top left photo, where the cryo device clears the cornea that is remaining. Even after penetrating keratoplasty, we will have obviously some cornea remaining as the host bed for the graft from the trophozoites and cysts. And then you can see in this particular case that we have a good result that is even giving functional recurrence, but that is not the primary goal in that show stage. But you can be lucky and get to that result with all sutures removed after 2 years on the lower right side. And you can see that we prefer the double running suture. So, and this was it. So I can summarize. The acanthamoeba keratitis is rare but serious. You have to sort of get the diagnosis early if you can, because early diagnosis gives better outcomes. It's always better to not do a keratoplasty show than to have to do it. And I think the most important message is to do prevention by means of educating your patients with respect to contact lens hygiene, because that's the most significant risk factor for this that we know. But it can really affect a perfectly healthy individual. Yeah, thank you very much for listening, and we can, I think, directly move on with the next presentation and do the discussion in the last part. And so it's a pleasure for me to introduce Reda Žemaitienė from Lithuania, a leading ophthalmologist from Kaunas Hospital, the head of Kaunas Hospital, and she will give a presentation on the management of fungal keratitis. So, Reda, you have the floor.
Good afternoon. Can you hear me?
Yeah, it's perfect. We see the slides and we hear you.
And you see slides. Okay. So first of all, many thanks to ERN-EYE and especially to Professor Daniel for this possibility to be here today to speak during this webinar. And many thanks to all speakers for today, especially Professor Thomas Reinhard, who agreed to share his so big experience. So the topic of my presentation, management of fungal keratitis. My financial disclosure. So fungal keratitis is an infectious disease of the cornea caused by any fungi capable to invade ocular surface. It is often a slow progressing, persistent condition that must be distinguished from any other microbial and viral keratitis. Fungal keratitis is one of the major causes of corneal blindness globally. More than 1 million cases of fungal keratitis occur annually, with the highest rates in Asia and Africa, where in tropical and subtropical regions, fungi may be accounted up to half of infectious keratitis cases. In Europe, fungal keratitis is relatively rare, with reported annual incidences ranging from 0.6 to 1.5 cases per million population in countries such as Ireland and Denmark. Fungi that lead to keratitis can be grouped into 4 categories: filamentous septate, Aspergillus, Fusarium, and others, filamentous non-septate, yeast, and others. The main fungi that cause keratitis are filamentous species, especially Fusarium and Aspergillus, and yeast fungi, mainly Candida. Risk factors for fungal keratitis. Trauma with vegetative or organic matter is the most common ocular risk factor. The increasing use of contact lenses, especially when associated with poor hygiene, is another important risk factor, particularly in developed countries. Other ocular factors include the use of corticosteroids, chronic underlying ocular surface diseases, and prior ocular surgery, such as refractive procedures or keratoplasty. Systemic risk factors are diabetes and immunosuppression. And finally, environmental and epidemiological factors are also important. Fungal keratitis is more prevalent among rural and agricultural workers and in hot and humid climates, while Candida infections are seen more often in temperate climates, also in eyes with previous ocular surface disease or surgery, and in immunocompromised patients. Pathogenesis, maybe I will skip. So, clinical presentation. Patients with fungal keratitis usually present with insidious onset and gradual progression of symptoms. Symptoms at presentation are minimal compared to cases with bacterial keratitis. The severity of signs is also less compared to bacterial keratitis, but virulent fungi such as Aspergillus or Fusarium species might lead to rapid progression with consequent corneal perforation and endophthalmitis, especially when corticosteroids have been prescribed. Because of that, a high degree of suspicion has to be maintained for early diagnosis and treatment. That is essential for a successful prognosis. Typically, in the early stage, filamentous fungal keratitis manifests as a gray-white, deep, non-suppurative stromal infiltrate with feathery margins. Corneal epithelium over deep stromal infiltrates might be intact. Typical fungal corneal ulcer has a dry-looking rough or grit texture and raised ulcer borders. Satellite lesions and immune rings are also very common. A fixed hypopyon and endothelial plaques may also develop, particularly in deep or large infiltrates, and their progression means infection extension into anterior chamber. In later stage, intense suppuration may develop with deep stromal abscess that resembles bacterial keratitis. And gray or brown pigmentation of corneal ulcer can also present, which is typical for non-filamentous dermatitis fungi keratitis. Yeast keratitis presents as well-demarcated yellow-white stromal infiltrate with overlying epithelial defect. Ulcer may have a collar button configuration. A small central ulcer is surrounded by a larger expanding infiltrate. It resembles bacterial keratitis, but has a slower progression, a more discrete stromal infiltration, and of course does not respond to topical antibiotics. Endothelial plaques and hypopyon are also common, but unlike filamentous fungal keratitis, satellite lesions and feathery edges are uncommon. Diagnosing of fungal keratitis requires a thorough patient's medical history assessment, clinical examination, and laboratory tests. Conventional diagnostic methods start with corneal scraping, which provides material for direct microscopy and culture. Several staining methods can be used to provide rapid and inexpensive diagnostics. But culture remains the gold standard for diagnosing, which has high specificity, low sensitivity, although growth may take up to 2 or even 3 weeks. In refractory or deep infections, a corneal biopsy should be performed, which provides material for histopathological analysis and culture. Molecular diagnostic techniques provide high sensitivity and specificity and rapid, within a few hours, results in detecting fungal pathogens. However, molecular diagnostic techniques are technically complex, require trained personnel, and expensive. Tear-filled biomarkers are a novel, non-invasive method, though clinical use remains limited. Oh my God, something has happened with my presentation. I will do it once again. Something. Just a moment. I'm not sure where I stopped. Yes, I think it was molecular detection. Yes, okay. Sorry. So advanced diagnostics. In vivo confocal microscopy is a highly sensitive, specific, rapid, non-invasive, real-time imaging modality for fungal keratitis diagnosing, especially filamentous. However, it has limitations such as the need for skilled technicians, patient cooperation, high cost, and it cannot differentiate between different types of filamentous fungi. Anterior segment of CT can assess the depth and extent of stromal infiltrate and is useful in monitoring disease dynamics. Typical OCT findings in fungal keratitis include stromal cystic spaces that shows tissue necrosis, stromal thinning, and endothelial plaques with indistinct corneal boundaries, which shows fungi diffusion from the stroma to endothelium. And artificial intelligence has been applied to analyze Lithuanian images and in vivo confocal microscopy images. Different algorithms are used to automatically recognize and differentiate fungal keratitis from bacterial and viral. Currently, a major challenge is the standardization of anterior segment imaging. Challenges of fungal keratitis management. First of all, delayed diagnosis is common and it worsens prognosis. Limited drug options and poor ocular penetration of many agents. And only natamycin 5% suspension is FDA approved and commercially available for topical use. Aggressive management is usually required, such as frequent dosing and prolonged therapy. And despite treatment, healing is slow and can take several weeks to months. Mainstay of fungal keratitis treatment is topical and start therapy as soon as fungal keratitis is diagnosed. Natamycin suspension is first line for most cases of filamentous keratitis, especially Fusarium species. Start hourly for the first 84 hours, then every 2 hours during waking hours until complete epithelialization, and continue 4 times per day. Amphotericin B is preferred for yeast keratitis, including Candida species, and voriconazole 1% solution is an option for cases unresponsive to first-line therapy, but we should remember emerging resistant is reported. Natamycin 5% suspension versus voriconazole topical treatment was analyzed in the mycotic ulcer treatment randomized trial, and natamycin showed significantly better clinical and microbiological outcomes than voriconazole treatment for smears positive filamentous fungal keratitis, with much of the difference attributable to improved results in Fusarium cases. And this evidence has established natamycin 5% suspension as the first-line topical antifungal agent, especially for Fusarium keratitis. Voriconazole is considered a second-line option, particularly in cases unresponsive to natamycin or caused by other fungal species. Natamycin suspension creates a good corneal surface concentration but has poor ocular penetration. And recently developed Natasol, which is a water-soluble 1% natamycin formulation, improves transcorneal penetration and increases intraocular concentration compared to the standard natamycin suspension. And a Natasol randomized study of 60 patients demonstrated significant reduction in time of corneal reepithelialization and the potential in promoting faster healing versus natamycin suspension and natamycin voriconazole combination. Also, other nanoparticle-based formulations are under research. The role of oral antifungals has been investigated in the mycotic ulcer treatment randomized trial 2, which compared oral voriconazole and placebo in addition to standard topical antifungal therapy. And this study showed no benefit to adding oral voriconazole to topical antifungal eye drops in the treatment of severe filamentous fungal ulcers. Moreover, patients receiving oral voriconazole experienced more adverse events. Though systemic treatment of fungal keratitis is controversial, if the ulcer extends to the limbus or in severe cases with deep keratitis, scleritis, or endophthalmitis, also in postkeratoplasty patients, systemic treatment is recommended. And several systemic azoles are used in clinical practice. Voriconazole is often preferred because of its excellent ocular tissue penetration and broad antifungal spectrum, particularly against Aspergillus. Intervention and surgical management. A mechanical debridement, especially in superficial keratitis, is useful and can be even repeated. Some authors recommend corneal epithelial debridement in deep keratitis to increase penetration of medication, especially of natamycin. However, clinical trial which compared topical natamycin versus topical voriconazole showed no difference in healing time when epithelial debridement was performed in addition to topical therapy in either group. On the contrary, there was a trend towards scraping being associated with worse outcomes. Targeted antifungal delivery, performing intrastromal and/or intracameral antifungal injections for refractory cases, especially with deep stromal infiltration or anterior chamber involvement. Here, some controversies also exist, especially regarding intrastromal injection. And these therapies may lead to deeper spread of infection and other complications. Adjunctive phototherapy. First of all, corneal cross-linking, which accelerates healing, speeds up epithelialization, decreases the risk of perforation in fungal keratitis. UVA-activated riboflavin generates reactive oxygen species with direct antifungal effects and induces collagen cross-linking, resulting in corneal stiffening and increased resistance to enzymatic degradation. However, studies results are mixed, and so far it cannot replace standard medical treatment. Novel treatment, rose-fungal photodynamic therapy. It can be considered in cases where conventional antifungal therapies may be insufficient or surgical intervention is challenging. This technique uses rose-fungal dye to generate reactive oxygen species upon activation, leading to cell death. And efficacy against Fusarium solani, Aspergillus fumigatus, and Candida albicans was established. However, no large-sized clinical studies currently available. And therapeutic keratoplasties. Indications for therapeutic keratoplasty, fungal keratitis not responding to targeted drug therapy, and corneal ulcers impending perforation or actual perforation. In general, DALK is more recommended in clinical practice, but if plaques are present indicating fungal penetration into Descemet's membrane or anterior chamber, therapeutic penetrating keratoplasty should be performed. And to summarize fungal keratitis treatment, the stepwise treatment algorithm proposed by Sharma is very useful. And this TST protocol was used widely in clinical practice and trials with the overall success rate around 80%. According to this protocol, natamycin is the first-line monotherapy and should be continued for 2 weeks after resolution of the infection. Usually treatment takes 4 to 6 weeks. If no response to natamycin at the 7th to 10th day of treatment, topical voriconazole or another antifungal agent is added according to established culture and sensitivity results. If the response is still poor after 7 or 10 days, intrastromal, intracameral, or combined injection of antifungal agents can be given, or corneal collagen cross-linking can be performed. Therapeutic keratoplasty is performed for unresponsive cases or perforated ulcers, and systemic antifungals if ulcer size is more than 5 millimeters or if it involves beyond half of corneal stromal depth, and duration of treatment after keratoplasty at least 2 weeks. But if histopathology reveals an infection of the edges of excised cornea or if infection clinically presents, therapy should be continued for at least 6 to 8 weeks. And almost the same protocol we use in our clinic. Prognosis. Prognosis is worse in cases with advanced age, delayed initiation of antifungal therapy, steroid use, and large lesions. Filamentous fungi are associated with more aggressive disease and poor outcomes compared to yeast. Therapeutic keratoplasty is required in approximately 1/3 to half of cases, but only 30 to 50% of therapeutic grafts remain clear at 1 year. Recurrence of infection after therapeutic keratoplasty from 10 to 20% and higher with aspergillus. Visual loss, in majority cases monocular, in 26 to 66%, and evisceration or enucleation is needed for 8 to 20% of cases. Perspectives. Overcoming species-specific antifungal resistance and poor corneal drug penetration remain key challenges. Advancing nanoparticle-based delivery and multi-targeted combination therapies offer promising treatment directions. Immune-targeted therapies represent emerging strategies that may balance antifungal activity with reduced corneal immune damage. AI-assisted tools can support early diagnosis and intervention, especially in rural areas. And public health efforts such as eye safety education, rational steroid use, and early referral are essential for improving outcomes. Thank you for your attention.
Yeah, thank you, Reda, for this excellent presentation. And I think we should just move on to the last but not least topic of today, that is neurotrophic keratitis. And I'm pleased to introduce Professor Pauklin from Tartu University Hospital in Estonia to give that presentation. Mikk, the floor is yours.
Yeah,
Excellent.
can you see my slides? But
yeah,
topic is a bit different. My topic is about peripheral ulcerative keratitis. Nevertheless, I would speak about this rather rare but still important condition. As you know, a peripheral ulceration is quite rare, but it may be a serious condition leading to visual loss. And that's why we have to deal with this constantly. And as we know, it is mainly related to immunological disease like rheumatoid arthritis. And in recent years, advances in treatment of this autoimmune disease have actually led to a reduction of the presentation of peripheral ulcerative keratitis. Especially the biological treatments and systemic treatments help to control the disease, so we don't see a lot of these patients anymore. But nevertheless, we see some patients who have a very severe disease or actually for any reason can't use some systemic treatments. Or have discontinued the treatment, and in these patients we actually have see peripheral ulcerations. So it is characterized by this peripheral thinning of the cornea and melting, and the reason why the peripheral cornea is actually involved is the proximity of limbal vessels leading to the access of immune cells to the peripheral cornea. Normally, of course, the central cornea doesn't have blood vessels, and that's why the peripheral cornea in this case is involved. And as I said, rheumatoid arthritis is the most common cause, leading, and it is detectable in almost 1/3 of the patients who have peripheral thinning and ulcerations. And it also can be combined with severe necrotizing scleritis, also related to systemic autoimmune disease. Nevertheless, when we see a peripheral ulceration, we should not forget other possible causes as also different other conditions may lead to peripheral lesions, especially infections. While most infections affect the central cornea, it is still possible that in some cases bacterial, herpetic, or also amoebic infections may lead to peripheral involvement, and especially in patients who have hypersensitivity to Staphylococcus stands, we see sometimes peripheral lesions, but in these cases, normally the epithelial defect is very small and it does not lead to epithelial defects and corneal melting, like in the case of peripheral ulcerations, really. In addition, also, of course, different chemical and thermal injuries may lead to corneal melting, and in these cases, normally we can detect the disease or the cause of the disease actually by thorough anamnesis. And eyelid disease leading to peripheral irritation by tracheasis, ectropium, entropium, and lapophthalmos in cases when the eye doesn't close properly may lead to thinning and corneal melting in the lower part. Other autoimmune disease like Morin's ulcer are probably actually very similar from the pathological mechanism, but in Morin's ulcer we don't find a systemic association, but the condition is very similar actually to the peripheral ulcerative keratitis we see in a systemic autoimmune disease. Tren's marginal degeneration is also a similar condition leading to a peripheral corneal thinning, but not inflammation, and it progresses normally very slowly and doesn't cause perforations unless the eye has a mechanical injury, or and in this case, it's a very thin peripheral cornea still can perforate. And of course, neurotrophic keratopathy also. So, as I said, from systemic conditions, rheumatoid arthritis is actually the most common one, but also other systemic autoimmune disease like Wegener's granulomatosis, lupus, and polyarthritis nodosa may also lead to this corneal thinning and ulceration. And skin conditions and rosacea, of course, may lead to lower vascularization, so vascularization of the lower part, and also some lesions, but normally also not melting. So eye is actually affected in case of autoimmune disease like rheumatoid arthritis. The reason is, of course, not quite clear, but it seems that histological composition of the cornea and sclera is very similar to the composition of different skeletal structures and joints, and this proteoglycans and collagens probably lead to a cross reaction in autoimmune disease, leading to also problems in the eye, so to say. So what pathological mechanisms are involved? The most important one probably is systemic vasculitis, leading to corneal and scleral melting and necrosis, but also different other systemic, so autoimmune mechanisms like production of different collagenesis, mainly matrix metalloproteinases, leading to the corneal melting and scleral melting, and also deposition of immune complexes is also very important, and that's why the proximity of blood vessels is important for the development of this disease. Clinically, we see normally like a peripheral lesion. It's an arcuate lesion that spreads along the limbus and does not really spread to the center unless it's a very severe form. And normally the size of the epithelial defect is similar to the size of the ulcer itself. And that's one possibility to distinguish it from the hypersensitivity reactions we see quite often in people who have blepharitis and develop lesions also in the peripheral cornea. So staining helps to distinguish it, and of course we see an irritated eye with hyperemia, perilimbal or pericorneal vascularization or hyperemia, and also peripheral corneal vascularization. Sometimes the leading edge is undermined and when it spreads to the center. Here's one more picture from one of my recent patients. So sometimes the lesion itself is quite large by the time the patient reaches an ophthalmologist. It's unilateral in most patients, but sometimes when we examine the second eye, we see that the patient has already had a similar event and we see a thin scar in the periphery of the second eye. So the patient may have had a similar episode in his first eye, actually. But in some cases, it's bilateral, of course. The eye is quite painful normally, may lead to, of course, photophobia, tearing, and loss of visual acuity, mainly from the irregular astigmatism and corneal opacity, of course, also. And the main fear we have is perforation, but because this can lead to corneal perforations in the periphery, and this is quite challenging to treat afterwards. So the main treatment actually is to control the underlying systemic condition itself, so rheumatoid arthritis in most patients. And it is important not just to control the ocular condition, but also to control the patient's systemic health, because it has been shown that the patients who have rheumatoid arthritis and develop a peripheral ulcer also have active systemic vasculitis, and these patients have actually increased mortality. And if the patients don't get systemic immunosuppression or its immune modulating therapy, these patients are quite likely to die within 10 years from systemic vascular complications. So systemic treatment is not just important for the eye, but really for the general health of these patients. And that's one thing we should communicate to our colleagues from the rheumatology department, that this is not just an ocular condition, but it's a sign of deteriorating general condition. So when the patient actually come in and have already an ulcer, then in these cases, of course, we start systemic treatment first. And we start with corticosteroids. In some milder cases, we could start with oral prednisolone, 1 milligram per kilogram per day. But in most severe cases, we would often start with intravenous pulse therapy with 1 gram of prednisolone and continue this for 3 days. And then in addition, also, we would, of course, start with systemic immunomodulatory therapy. And at least in Estonia, but also I think in most other countries, ophthalmologists are not very comfortable by using this therapy because it may have systemic side effects. So good collaboration with our rheumatologist is important, and normally we start treatment in collaboration with our colleagues. So antimetabolites that inhibit B and D cells is one of our first choices in addition to corticosteroids. And methotrexate is the first choice in our clinic. And we start with 15 to 25 milligrams per week. And these patients, of course, should be monitored because they may develop bone marrow suppression and our colleagues, of course, regularly check blood counts and metabolic panels, of course, in these cases. And of course, in recent years, we start also with DNF alpha inhibitors, so biological therapy, adalimumab or infliximab. But these patients, of course, will be monitored by a rheumatologist. And the very severe cases who do not respond to the first line of treatment will need cyclophosphamide. But in these cases, we should be very careful because this may cause very severe side effects like bone marrow suppression and infections, and of course also increased risk of malignancies. So these patients should be monitored very, very carefully by a rheumatologist. So as an ophthalmologist, what could we do? We start of course by preventing secondary infections. We always take first, of course, cultures from these ulcers to find any secondary infections, and start also treatment with antibiotic drops or ointments to prevent any secondary infections because the patients have an epithelial defect. So second aim for us would be to promote epithelialization because when the ulcer closes or the epithelium is closed, then the patients will have not a high likelihood of corneal melting and perforation. So just lubricating drops in addition to the antibiotics or ointments would be quite useful or should be used. And of course, we also want to prevent perforation, and for this we would use acetylcysteine, so this ACC eye drops. And in our country, we don't have special eye drops. We use solutions that are actually for injection, and this 10% acetylcysteine can be just used as an eye drop to reduce activity of matrix metalloproteinases. And for this, we normally add also doxycycline tablets. It has also an effect on the matrix metalloproteinases. And to also promote collagen synthesis, we add normally vitamin C that is also important for the collagen synthesis. And we try to avoid corticosteroid drops and injections because this might promote corneal melting. But when we see a corneal perforation, then the condition, of course, is difficult. We have a peripheral lesion, meaning that when we use a corneal transplant, or then there is a quite high likelihood of rejection afterwards because of the proximity to the limbal vessels. Nevertheless, to save the eye, there is we have often no chance, no other possibility to close a wound with either a small or large corneal graft, or sometimes reaching up to the limbus and covering the whole corneal ulcer. Historically, resection of conjunctiva in the area of the ulcer has been used. The results are mixed. The idea was or is actually to prevent immune complex deposition in this area by removing the blood vessels. And it has been shown to be effective, but we have not used it in all cases, I have to say, because the bare sclera itself is something we are afraid, because we are also afraid of scleral melting in these patients. So it's a mixed. So it's a use of the conjunctival resection is not very common in our clinic. So we should always communicate to the rheumatologist who follow these patients that they should really send the patients to us when the patients develop decreased visual acuity quickly, and the patients should come to our emergency room when they have severe pain or especially a red eye. So these patients, of course, have often dry eyes, and it's sometimes difficult for the rheumatologist to recognize this condition. But when they see decreased visual acuity in these patients, we would rather see these patients early and try to prevent perforations, if possible, not treat already perforated corneas. So this is all from me, and I thank you.
Yeah, we thank you. Nice presentation, Mikk. And now I think we are done, and we can open the discussion. So are there any questions from the audience? You can also use the chat if you want to ask a question.
May I ask you?
Yeah, feel free.
Yes.
Go ahead.
So, I would like to ask Professor Reinhard regarding antiviral treatment. Which you prefer? Which one? Acyclovir or valacyclovir? I mean, a systemic treatment.
It depends, as usual. I indeed prefer valacyclovir. It is valine plus acyclovir, and it penetrates the gastrointestinal tract more easily. So you have comparable levels of acyclovir in the blood, but it is much more expensive in Germany. So we start with the valacyclovir and try if the insurance pays for it. And if the insurance refuses, we switch to the alternative, that is acyclovir, second choice.
Thank you very much.
So I can, sorry, go ahead.
I would like to ask a question. Is this possible?
Yes, go ahead, please.
I'm from the AKI Foundation, the first patient-driven organization for AK patients. And I would like to thank you, Dr. Böhringer, for raising awareness on this topic. And I listened to all the presentation with great interest, and I realized that many keratitis get worse through the use from steroids. So in viral infections, they are usually applied in most cases, as I understand, and in acanthamoeba keratitis, in this last presentation about this POK and other keratitis, it's getting worse with steroids. I would like to know from Dr. Reinhard, why is it necessary to apply steroids very early with viral infections?
So it depends. Thank you for the question first. It depends on the case of infection. If you have dendritic keratitis due to herpes simplex virus, never use steroids. If you have infiltration, chronic interstitial keratitis by the virus, or even endotheliitis or an ulcer, you have to. If you only use the virus stasis, it won't ameliorate. You have to treat both alterations, that is the viral replication by the virus stasis and the immunological response by the steroid. You have to administer both. So if you only give the virus stasis, it doesn't improve. If you only give the steroids, it will even get worse. So administer in these cases both agents.
And may I ask what would happen if you first would rule out, for instance, AK through in vivo microscopy? So this would take maybe 1 or 2 days for referral to a center with this gadget, and only then start the steroids, because steroids make AK really much worse.
So I think it is not important, the 1 or 2 days, you have it. Mm-hmm. But in the long run, let me say after 3 or 4 days, you really should you should start the combined therapy.
Okay.
But the day doesn't matter.
That's great to hear that at least the first days you could wait with steroids and make sure it's not AK.
Yeah, absolutely.
Thank you very much for your answer.
Yeah, you're welcome. And there's another question from the chat. It's from Juliette Villa Sinclair Spence, and it's I will read it for everybody. Why, when talking about contact lens use and contact lens hygiene, it's not clear stated that water and contact lens should not mix? I would do no showering and swimming. Most case of AK are due to it. We see in our foundation. Okay, it's again an advice from for the prophylaxis. So yeah, I think that should be made clear whenever a patient is prescribed a contact lens, or when the contact lens is sold to the patient. I think then there should be some training and education of the patient, and we only can do our best to bring that, to raise that awareness in the community. But there's always the possibility that the patient will get it from the internet without any teaching, and I think then we cannot do much about it. But you are perfectly right to state that hygiene is absolutely mandatory when you do when you wear contact lenses. Yeah, thank you.
Am I allowed to add a bit?
Yeah, go on.
So I'm not sure. If we look at millions of contact wearers in Europe, we have 100 cases of acanthamoeba keratitis in Germany a year. We have less than 100 in UK. We have perhaps 100.
Oh, we lost your microphone. So, sorry, the microphone went off.
I closed it. Okay. Now you can hear me?
Yes.
We have millions of contact lens wearers in Europe. And we have only, let me say, 100 acanthamoeba keratitis cases in Germany a year. We have 100 more in UK. We have less than 100 in France. So it's really a rare disease, and we have to ask why. Millions of contact lens wearers, but only very rare numbers of amoeba keratitis. So I think it's not only due to hygiene. About 50% of the containers for contact lenses are contaminated with acanthamoeba agents. So once more, the question: why do we have so rarely amoeba keratitis? And I think it may be due to immunology. If we look at the patients, we have a difference between IgA in the tear film in patients with and without keratitis. So maybe immunology plays a greater role than we think today. IgA in the tear film possibly avoids amoeba keratitis. We do not know, but there are hints in literature.
Yeah, you're perfectly right. Thank you. But I think the question was about the general hygiene. So maybe we can prevent some bacterial ulcers also if we have better hygiene. So maybe still it's quite useful to talk to the patient to stay aware of not overwearing the contact lenses and so on. But thank you very much. So, and are there any other questions or comments? So I don't see any, so I can, I think, close this, wrap this up. So thank you very much for the speakers and also for the organizers from the ERN office, and to you, audience, for having us. And we are looking forward to the next webinars. You can look on the ERN website to keep informed on that. And I wish you all a very nice and pleasant rest of the day. Goodbye.
Thank you.
Thank you and goodbye.
Thank you.
Thank you.
Thank you
Thank
very
you very
much.
much.
Goodbye.